So before I introduce today's speaker, one thing I want to do is look ahead. We're going to have a couple weeks off, spring breaks next week, and then we're going to reconvene on the 30th of March, and Wendy Lynch is going to be speaking, however, virtually. You know, unfortunately, she's not coming here in person, but she's going to talk about sex, gender differences, and substance abuse disorder. And then the week after that, on April 6th, we're going to have Leon Coleman come over from our sister institution down the road here, down Tobacco Road, actually, they call it, I think. Immune mechanisms underlying alcohol-induced behavioral pathology and degeneration. And he will be here in person. And Christina Mead is going to speak in April, as is Rena Dossi from Penn State University. Then we're going to kind of do things a little bit differently in the fall. Stay tuned for that. We're going to kind of join forces together with CNN and some of the other groups and have a series of major speakers, and then probably have also some smaller kind of brown baggish sort of talks as well. So anyway, today I'd like to introduce my colleague and friend, Dr. Yousef Tizabi, who is a professor in the Department of Pharmacology at Howard University, earned his bachelor's at UC Berkeley, his PhD at Georgetown University, and has been a longtime leader in the field of both nicotine and alcohol effects. And he's going to speak to us about alcohol nicotine addiction, neurological substrates, and pharmacological exploits. Yes.
Thank you so much. It's such a great pleasure to be here. It's not my first time at Duke. Attended the nicotine conference a couple of times, and the friendship and association goes a long way. And because of that friendship, I'd like to dedicate this talk to my two good friends, Ed and Amir. And you'll see the collaboration as we go along. So before I start, I want to tell you a little bit about Howard University. As you see, it was founded in 1867, right after the Civil War. So it's 156 years old. And the reason for foundation was that General Howard, Otis Howard, was in Lincoln's cabinet, and to give a homage to Black soldiers that had fought with him, petitioned the Congress for a center of higher education. And it was approved for a seminary school, was way above Washington. Then following year, they decided to establish a medical school because there was hardly any Black doctor, of course. And since then, it has expanded throughout the years. It has the motto of providing education for people who could not otherwise get it anywhere else. And that meant African American, Black, and minorities in general. And so it got expanded. We had all the disciplines. It is located in a very nice area now of Washington, D.C. We are only a few miles from the Capitol or the White House. And the hospital that was associated with the medical school later on, initially it was called Freedmen's Hospital. And it was not the name of Freedmen, but for freedmen, actually. And now it is still the institute that produces the most number of Black PhDs, as well as doctors. And this is College of Medicine. I am on the third floor of this building, but there are also non-Black students and mostly from islands and so on. It is the first HBCU, or historically Black college or university. So we are the Harvard of HBCUs. And It is one of the only two institutes, I believe, that gets direct funding from federal government. The other one is also in Washington, D.C., Gallaudet University. That's University for Deaf, basically. And we were getting 100% at one time. Now the support is about 25%. It's still pretty good.
So, Yousef, I want to point out that here on Duke campus, Sealy Med Building houses our medical library.
Yes, and apparently there are many places with the CVG mud. So I think this is the view from my office. This is our new library. I think Amir visited me there. Ed was, and I think Jet, anyways, this is where you would, what you would see if you visit my office. And I hope that you would be coming there someday. I'm going to talk about two similar concepts, nicotine and alcohol, and basically why addiction in general and to nicotine in particular. And same things for alcohol, comorbidity with psychiatric disorders, neurochemical underpinning, and the age and gender influence. I don't need to preach to the choir here that smoking is a big problem. It's one of the perhaps easiest preventable disease. You get, or deaths get close to 500,000 people in the United States. Worldwide, of course, is a lot more. And right now, with all the efforts, seems like we have reduced the incidence of smoking maybe to, don't know, Jet would know better, to 20% or so. But it seems like it's a cutoff line that we cannot go too much below that. And the reason I think it's because of this substance, nicotine, which is a rather simple molecule, can be synthesized easily. This is the flower of the tobacco plant, beautiful flower that leads to tobacco. And when you burn this tobacco, you get this chemical nicotine that is, as we know, a very potent stimulant, highly addictive. And the reason for this addiction is many different reasons. One is that it's anxiolytic. People that smoke, say, stress, reach out for a cigarette, calms you down. It has antidepressant, and this is where we started with Amir, and coincidentally, we were at a neuroscience meeting. I think David Overstreet was working with and Amir with FSL, the Flinders Sensitive Line Rise of Depression. And there was the understanding that the incidence of smoking is a lot higher in depressed population, whereas it might be 20, 25%. In general population, it's at least double that in depressed. So there was the hint that this might be a way of self-medication. And they had the animal model who said, let's try nicotine, see if it does do antidepressant effect in this model. And indeed it did. And that is one of the highly cited papers, was over, 15, 20 years ago. In addition to antidepressant, it has a very potent antipsychotic effect. In fact, it's thought that the schizophrenic patients are chain smokers, and they are self-medicating again with nicotine. There is also, Ed is the expert in this, that has cognitive enhancement effect. And this might have some actually clinical relevance to mild cognitive impairments. And I believe our colleague friend, Paul Newhouse, is trying the nicotine patch in mild cognitive impairment in various centers.
Yeah, there's a major study.
But I am gonna interject something here that I don't think nicotine patch is gonna be as effective, and I'll tell you why later. The reason is that with nicotine patch, I'll give you the prelude, you cause desensitization of the receptors. Whereas smokers take a puff, stop, they have withdrawal overnight, the next day, the first cigarette is the best. It's the pulsatile stimulation that you need. And I'll keep coming back to that as well. It has analgesic effect. In fact, the most potent analgesic agent ever discovered is epiballidine that is derived from the skin of Ecuadorian frog. And our colleague at Georgetown, Ken Keller, had a very nice review on that, except it is got side effects that cannot be used clinically. I'm gonna talk to you about its neuroprotective effect as well. That's the pharmacological exploits, other therapeutic potential. So ADHD, attention deficit hyperactive disorder. This is how I got involved in nicotine. Before that, as a young scientist, I was pursuing the idea of stress and aging, and I had the hypothesis that stress accelerates the aging process. And except for myself and a few other friends, I could not prove to NIH to fund me, because both definition of stress and aging was very difficult. Anyways, I had a young student coming to me saying, want to work with you? I said, this is what I do. Say, stress, oh, do you have something else? That day I was in the library, I was reading that the mothers who smoke during pregnancy have higher incidence of ADHD kids. Well, this could be a project, if you like. We can get pregnant dams. There are mini pumps that you can administer nicotine with, and look at that. So we developed a project. We looked at the offspring, looked at dopamine receptors in striatum, published a paper. She got her PhD. The offshoot was that you get an increased release of decrease of dopamine in striatum and decreased dopamine D2 receptors specifically. And then for Tourette's syndrome, actually this last month, there was an article saying that the ADHD people also have a tougher time quitting because it might be, and it makes sense because we do treat the ADHD with stimulant like methamphetamine, and nicotine could be another substitute perhaps. Tourette's syndrome, same with another colleague, Darmani, was at Clarksville in Missouri. Then he had a model of Tourette's syndrome. It would give the mice a 5-HT2AC agonist, and they would have the head twitch. We figured because of the comorbidity, ADHD, Tourette's syndrome, and OCD, maybe nicotine would be effective there. And it had another student worked on that, got a couple of papers on that, and indeed it works. And for OCD itself, we also had a model where you could give quinperol, which is a D2/3 agonist, and the rat model of OCD, Henry Shetman in Canada had a very nice model. We tried nicotine, and that got published in Biological Psychiatry. And it has nicotine anti-inflammatory. That's why it might be used in ulcerative colitis and whatnot. So, whereas nicotine, should say the reverse, smoking can be so hazardous, kills, nicotine can have definite therapeutic potentials for all the cases I indicated. And this, I was in botanical garden in Washington, and I saw this, that tobacco was used as a sacred chemical to honor the earth and creator, and it was smoked to signify peace and burned to purify and protect, basically. So in terms of the mechanism of action, we know it is acting on ligand-gated ion channels. Once it binds, opens the channel, and you get the flow of sodium and export of potassium. You have these receptors at neuromuscular junction. You have them in all autonomic ganglia and in central nervous system. However, the composition of the subunits are different in neuromuscular junction, like you have gamma and delta, which is not available in CNS. And in ganglia, you have separate. In CNS, the two most highly studied are alpha 4 beta 2 that contains, or homomeric alpha 7. And because acetylcholine was the first neurotransmitter to be discovered, we know a lot about this receptor. It was isolated from the eels, and we know more about these receptors than any other one. Of course, the body doesn't make nicotine to have nicotinic receptors. We know that this is the receptor for acetylcholine, which is a very important neurotransmitter. And in fact, the involvement of acetylcholine in cognitive function is one of the most prominent. And in Alzheimer's, this is the neurotransmitter that is first and most affected, like dopamine in Parkinson that I'll be talking about. And for cognitive enhancer, or to enhance the effect of acetylcholine, what the drugs are being used for Alzheimer's are really acetylcholinesterase inhibitors, because acetylcholine gets broken down very quickly in the synapse. And the inhibitors of these, where tacrine was the one that was most widely used. Now we have donepezil that was, I think, produced by Eisai Pfizer. I was proud that my first student was involved in promotion of that donepezil. Still, it is mild effect, and we really don't have any real effective therapy, as you know, for any cognitive enhancement, except perhaps nicotine. But we know that acetylcholine acts on both muscarinic and nicotinic receptors. And for a long time, the focus was on muscarinic, but we know that nicotinic might be the more important one. The same thing in Parkinson. Don't need to elaborate on that. It's a movement disorder, have the rigidity, walking, tremor, and all that. And in this case, we know that the problem is with the nigrostriatal dopaminergic system. So the neurons in substantia nigra start degenerating. We don't know exactly why, but some chemical toxicants, pesticides, paraquat might be one of them that affects this circuitry. So this nigrostriatal is involved in movement. Parallel to that, very close, we have the mesolimbic system that starts in VTA and goes to nucleus accumbens. And this is the dopamine system that is involved in addiction. And there is, of course, another tuberoinfundibular, the dopamine from hypothalamus to pituitary, that basically regulates prolactin release. So for Parkinson, as you know, we have L-DOPA that gets converted to dopamine in the brain, and this kind of alleviates the symptoms for a long time because it replaces the dopamine or you can have the enzyme inhibitors. There are two enzymes that inhibit dopamine. One is monoamine oxidase or catechol-methyltransferase, or you can even block the uptake of dopamine. Any which way you can increase the dopamine, you have relief of symptoms. Unfortunately, the treatment with L-DOPA is good only for a few years, and then you start developing resistance. And sometimes L-DOPA-induced dyskinesia, which is even worse than the tremor itself. You have to reduce the dose, give other agonists. But regardless of what we have in this case, we are doing a symptomatic treatment. We are replacing dopamine, and the neurodegeneration is continuing. Maybe that's why L-DOPA is not any more effective, because the remaining dopaminergic cells are dying, and you need some reservoir to have some effectiveness. And I believe that nicotine might be such a compound that would not only increase dopamine release, but also prevent or at least delay the progression of this devastating disease. And the way I think it should work or should be given is by pulsatile stimulation. And the pulsatile stimulation of nicotine would be more or less the same as you would take a cigarette, except you would need pure nicotine. It would be given by inhalation or nasal spray. That would be very effective. So the reason for this, of all the ill effects of smoking, one thing has been established over and over in all epidemiological studies, and that the incidence of Parkinson is less in smokers. So I'm going to pause here a minute to caution and say, please, 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 don't take smoking as a way of delaying Parkinson, because you might not get to that age because of what we were talking about. Right? So you really need to have pure nicotine and in a pulsatile form. Okay? So in addition, as mentioned, nicotine has antidepressant effect. There is a very high comorbidity of Parkinson and depression. So giving nicotine, pure nicotine in a pulsatile, could probably hit both of those targets at the same time. In fact, we just got a patent for pulsatile stimulation of nicotinic receptors in Parkinson patients. Just need to find someone to do a clinical trial. So in terms of the age and sex dependency, I won't go too much into this because you're going to have a speakers that discusses this in more detail. And I'm going to show you one of the two studies. One EDS 2007, showing that effect of aging, twofold higher levels of nicotine intake and faster acquisition of nicotine self-administration in adolescents versus adult rats. That was the age and the sex dependency. The current hypothesis is that same thing for alcohol, that we use, have both men and women use it, but for different reasons. Think that women tend to be less sensitive to the discriminative effects of nicotine and tend to regulate nicotine intake less precisely than men. On the other hand, women appear to be more sensitive to the effects of nicotine in reducing the negative affect, like as antidepressant, and the same with alcohol and reducing body weight. And men smoke more for the enforcing effects of nicotine, whereas women to regulate mood. And this is pretty much the same with alcohol as well, as I'll be discussing. In addition to the receptor activation, a very promising field now is the gut-brain axis. Basically, any drug or the circuitry that is affecting the brain might be going through the gut. So there is the gut-brain axis, and this is a really very fertile field for newcomers into the field. And there are many very interesting reviews on this, how the gut affects the brain and vice versa. More detailed, specifically affecting the microglia, which are regulating the central inflammatory response. So there is the gut, microglia, brain, and this is all very fertile, new, and potential therapeutic intervention as well. As we know, short-chain fatty acids, butyrate might be one of such chemicals. I want to discuss alcohol, exact same four concepts: why addiction, comorbidity, neurochemical underpinnings, etc. Alcohol has also a very long history. Probably it was the first ever drug to be discovered as a psychoaffective. The oldest, according to Guinness Book of Records, was about 6,000 years BC in Georgia. But last year, it was discovered that some of the clays might have some of the showing of some alcohol that would go 7,000 BC. So it's the oldest drug. It has a very simple, even simpler than nicotine. You have two carbon atoms and the hydrogen hydroxy group. This is also referred to as ethanol versus methanol, which is also referred to as wood alcohol, because by distillation of wood, you can get this chemical, which can actually cause blindness, and it is totally different from ethanol for change of one molecule. But so this is what the addiction is too. As you know, drinking is also a big problem. There is not as much as smoking. And in my opinion, the biggest difference between alcohol problem and nicotine problem is that nicotine is self mainly, a little maybe secondhand smoke. But alcohol is not only you. You get behind a car with a disturbed sensory systems and then family problems, all that. And this is unfortunately universal. I was surprised to see that in Denmark has one of the highest alcohol use. And why so popular? We were attending the alcohol conference in Nice with Ed and Amir, and George Koob gave the preliminary talk, and he was saying that it is a coping mechanism. I would totally agree and would add that it might be an escape mechanism, escape from stress. And this is probably with any drug of abuse. It's dissociating yourself from reality. Opiates, of course, biggest dissociation, relief of pain. And it's very popular. You remember, or you have read maybe about the inhibition. We want beer, not only men, women as well. So it's not discriminated. And in terms of the escape, this I saw a few months ago in Hecton, that this nurse, she said that she would not be able to do her job if it was not for a sip of liqueur. And it's really a coping escape stress mechanism, which unfortunately becomes a problem. We know alcohol, like any drug, is pharmacological drug, is dose dependent. This is probably what people want to get, the high. But of course, as you get more, and unfortunately you hear about fraternity rushes that let someone naive drink a lot of alcohol and can cause death. So alcohol, I'm going to tell you honestly, in a low concentration can actually have some beneficial effect. But nobody wants to say that, especially NIAAA, because people do this, say, oh, if little is good, then a lot is, see how fabulous it's going to be. And I like this other dose response of laughing out loud and I'm here, I'm fine, and then hospital. But the one that really describes all is that alcohol is not the answer, it just makes you forget the question. It's really the escape. So, and alcohol is also I was visiting my alma mater, went to the dorm and saw this saying in one of the dorms, give beer to those who are perishing, wine to those who are in anguish, because it makes them forget their misery. Again, escape. In terms of the gender, we think that women use alcohol for self-medication, especially for depression, and men use for high, especially with teenagers that they start. But because you develop tolerance to alcohol, no matter what the reason for the start, you eventually have to get more and you mess up the circuitries in the brain and you can actually exacerbate depression. Maybe initially was to alleviate, but then it's going to cause a lot more of that. And the depression, as you know, is a clinical issue. I'm not going to go too much into that, except that suicide is, of course, a very big problem. Hopefully, preventing of getting to that despair might prevent this suicide as well. And I have this in my office to remind me how important this thing is, not only in military, but in general population. So the topic I want to concentrate on, why smoking and drinking go together, why people who smoke want to drink and vice versa. And I'm gonna discuss three basic, again, same thing in young kids in college, very common positive reinforcement of the two together. And this is very interesting because both alcohol by itself and nicotine, smoking by itself can increase the incidence of cancers, especially head, neck, esophagus, as well as duodenal ulcer. But when you put the two together, it's no more additive, it's synergistic. It's 5 plus 5 is like 25 times higher the risk. So the question is why, despite these risk factors, they are co-abused. And the contributory factors, we can have some genetic component, some pharmacokinetic interaction, pharmacodynamic interaction, and this I'll talk about some additive reinforcement. Basically, both of them increasing the dopamine in the mesolimbic system. In terms of the reward, they both have analgesic, and I'll show some results on that. and counteracting mechanism. Alcohol is in general a depressant, pharmacological agent, whereas nicotine is a stimulant, so one can counteract the effect of the other. So you drink, you get a stimulant, you can drink more till you know the story. And this is the stimulation versus sedation, and there is the neuroprotection versus neurodegeneration. Like I said, nicotine does have neuroprotection, and alcohol, especially in high doses, can cause neurotoxicity. And here, Ed is getting into epigenetic mechanism, and both of these drugs have definite epigenetic components. As far as the reward circuitry is concerned, I mentioned there is the mesolimbic reward pathway, starts in VTA, goes to nucleus accumbens, and any which way you stimulate this circuitry, you can have a pleasurable effect. And basically all drugs of abuse, one way or another, stimulate this circuitry. Might not be the only one, but it's a main trajectory that is hijacked by drugs and produces addiction. And in terms of the alcohol and nicotine, we know that there are nicotinic receptors strategically located in the VTA as well as the accumbens, and stimulation of these receptors in either place would cause increase in dopamine release. And I would not go into the details of the microdialysis analysis, but we just showed, this was a paper long time ago, that both alcohol and nicotine by themselves can increase dopamine release in nucleus accumbens. This was alcohol by itself. Then we did nicotine by itself, dose dependent. And when we took very small doses of nicotine and combined it with the small doses of alcohol, we saw additive effect. So having additive reward, us being the nature of seeking reward pleasure, why not combine it the two together? And we showed that nicotinic receptors are involved in these, because you could block the effect with mecamylamine, which is a non-selective dopamine receptor antagonist, and or other nicotinic antagonists. I won't go into details, but basically you can have nicotinic antagonists as suppressing of the alcohol intake. So in terms of the summary of this combination effect on reward pathway, we can say that they have an additive effect contributing to their co-abuse, and at least some of the effects are mediated via nicotinic receptors, and that nicotinic antagonists may be potential use in this condition for alcohol abuse. Now, in terms of the analgesic effect, again, I mentioned the analgesic effect of nicotine, and our colleague Imad Damaj has worked a lot on nicotinic system in analgesia. And of course, the circuitry for analgesic pathway is very different. You start in the central gray area, and the circuitry is different, but the opiates are one of the most important regulators of this circuitry, the opiate receptors. And our hypothesis was that when you combine the alcohol and nicotine, you get more release of these opiates, and then you get more analgesic effect. And we did two tests, the tail flick test and the hot plate test with a postdoc, Vera Campbell, and found that indeed, when you combine the two together, you get additive effect, and that you can block these effects by specific opiate antagonists. So that we published a couple of papers on that. So again, just to summarize, is that the combination of submaximal doses of alcohol and nicotine can result in spinal or supraspinal mediated analgesia. One is tail flick, the other is hot plate, and this might contribute to their co-abuse, and that the analgesic effect is mediated by opiate receptors, and selective opiate antagonists may be of potential in drinking, smoking comorbidity. In fact, we know that opiate antagonists are the first drugs to be used for alcohol abuse. Naloxone, naltrexone is widely used on different perhaps of that, but this might fit into the potential comorbidity as well. So in terms of the final aspect of the antagonism of toxic effects of alcohol by nicotine, is that we know alcohol can have neurotoxicity, and we had primary cell cultures of cerebellum or cortex, and we see a dose-dependent toxic effects of alcohol. And when we give nicotine dose-dependently, you can block this toxicity of alcohol, basically completely blocking the effect of alcohol. And we can block the effect of nicotine by giving mecamylamine, which, as I mentioned, is a non-selective nicotine antagonist, or two selective antagonists of nicotinic receptors. One, dihydrobeta-erythroidine, which is selective for alpha-4 beta-2. It blocks the effect of nicotine. And or MLA, methylcotrinine, which is alpha-7 antagonist. So the fact that you can block nicotine effect by a non-selective antagonist or selective alpha-4 beta-2 or alpha-7 antagonist says that both of these receptors are involved. And we also, to carry out further to see what's the mechanism of alcohol toxicity, we showed that it is due to apoptosis, and that you get the increased caspase-3. And when you give nicotine, you can dose-dependently block this apoptotic effect of alcohol also. So in summary, this we did in both cerebral as well as cortical cell cultures. And the summary here is that alcohol dose-dependently causes toxicity, and this is mediated via apoptotic mechanism, and this toxic effect can be blocked by nicotine. Now, we know toxic effects of alcohol can be blocked by nicotine. You would probably not want to give nicotine to a person suffering from alcohol toxicity because of that co-abuse that I mentioned. However, we did a study with Ed and Amir again that ketamine, that is an NMDA antagonist, might actually reduce both the self-administration of alcohol and nicotine. So NMDA antagonist or modulator might be a good way to go. I should add here that nicotine itself might not be the most suitable in this case, but we now know there are nicotinic modulators that might not have the same side effect as nicotine, and they might be a good approach in terms of the pharmacological study and interaction. So that is to be determined. We are actually getting into the modulators to study their effects as in addition to nicotine in terms of the neuroprotection. Because again, always there is this concern. If you are giving nicotine, pure nicotine, of course, to a Parkinson patient, right? It's always this, what about the addiction that you're going to cause in these patients, right? Honestly, my opinion, I would say I have no concerns whatsoever because these are at the progressive older age. And it's like you say a diabetic person is dependent on insulin, they have to take it lifelong. It's helping them. And at that point, if it helps, why not? So addictive, they are dependent on it, you need it anyway. So regardless of addiction, you have to give it. So anyways, that's my argument against that potential side effect, especially for a neurodegenerative disease like Parkinson, or even worse, maybe Alzheimer's, that might have some effect there as well. So in terms of the alcohol-nicotinic interaction, we said that the reward pathway, analgesic pathway, or the counteraction can be contributing to the potential co-abuse. I want to take a few moments and talk about alcohol itself, a little bit of a mechanism of action, and some potential novel approaches as well. So we know, unlike nicotine, there is no specific receptor for alcohol, but alcohol affects practically on all receptors, affects all neurotransmitters, affects the lipid membrane, heat shock proteins, and practically all receptors, including nicotinic, and it is affecting the immune system. And this was interesting because with the COVID, the prognosis in alcoholic was worse because the high alcohol can suppress the immune system. And of course, COVID can have more dramatic effect in immune compromised patients. So that was another double whammy in that case. Now, high alcohol, we know, causes neuroinflammation. You get increased release of pro-inflammatory cytokines, TNF alpha, IL-1 beta. It can cause microglia activation and all detrimental effects. Neurotoxicity that with those that are highly dependent can be even irreversible because of the toxic effect that it has caused. Low alcohol, however, has the opposite effects. Decreased inflammation, decreased microglia activity, all the components that are adversely affected by high alcohol is in opposite direction with low alcohol. So this says perhaps moderate alcohol would be good. But again, NIAAA would probably be very cautious because of that cartoon I was showing that people say, okay, a little good, a lot more. So I have a feeling they don't want to advertise this, and they would probably emphasize the negative effect of alcohol. For sure, you don't want to have any alcohol during pregnancy, but other than that, moderate doses, I would think, I still believe that moderate, saying 1 glass of wine or 1 can of beer per day for women, maybe 2, 1.5 to 2 for men would be considered low or moderate would be effective. And this is where the French paradox was started, that French have a very high incidence of, have very low incidence of cardiovascular disease compared to other cultures, despite the high fat food that they consume. And they thought it was due to the resveratrol in the wine. But that resveratrol in the wine, we have done some studies, you need tons of alcohol to get enough resveratrol because the bioavailability is very low. and it is indeed the alcohol that might be doing that beneficial effect. So potential beneficial effects of alcohol, again, cardiovascular, the French paradox, neuroprotective effect, and we have shown in vitro that it has definite protection against succinyl-induced toxicity, and maybe even in some neurodegenerative diseases, that really low dose might be effective. Speaking of low versus high dose, I have to share this with you, my pharmacological point in a way, that any drug in a high dose can be toxic, in very low dose ineffective, and there is a window of therapeutic potential. This also goes for any poison, toxic, that we know even very low amount of botulinum toxin can kill, but much lower amount can have therapeutic potential, and that's actually being used, right? So, and that concept is called hermesis. That means a very low concentration of a toxic chemical can be therapeutic. And of course, this has to be tested in many compounds. Now, again, an area of fertile research would be to look into the gut-brain axis and the effect of alcohol. Here, you not only have the gut, but also the liver, because we know liver is one of the sites that gets affected by high alcohol, cirrhosis, kidney as well. So now we are expanding the gut-liver-brain axis, and soon probably the kidney would come into play. So this is a very fertile area because you, as I mentioned, affect all the transmitters via neuroinflammatory processes and probably the neurotrophic factors, BDNF and so on. So in summary, take-home message, addiction is not an easy problem. I think Ed might say it's an easy problem. I think if it was easy, we would have solved it long time ago. Men and women respond differently to alcohol and nicotine. We understand it, but to solve it is a very difficult issue. It's like same thing, stress, we know, but to avoid it, and worse than that, aging, how can we avoid that? So there is usually a comorbid condition in terms of the combination of drugs with neuropsychiatric conditions. I mentioned nicotine self-medication in schizophrenic patients, depressed patients, maybe other conditions as well. And so understanding the neurobiological substrates, including the gut-brain axis, would be a really good area to concentrate on. And there were a lot of people with this, and I want to acknowledge Ed and Amir, my two colleagues here, to whom I dedicated this talk. And I thank you very much for your attention.
Thank you. That really hit the gamut in terms of the variety of effects of nicotine and alcohol. We do have a few minutes for discussion.
Absolutely.
Recognize Jed.
Yeah, hi. Thanks so much. That was a wonderful tour through so many fascinating areas of addiction. And I just have a question about on the neuroprotective effects of nicotine against Parkinson's disease, and which are quite consistent and early on with smoking. And I agree with your conclusion that it's likely the nicotine, because even though smoking has thousands of constituents, including MAO inhibitors that might exert a protective action, smokeless tobacco has also been shown to be protective against development of Parkinson's disease. And smokeless tobacco, doesn't have much MAO inhibitors at all. Also, Marika Quick, who you've cited, and others have shown that administering pure nicotine in, for example, a monkey model of MPTP toxicity of dopamine neurons protects those neurons from degeneration. So it really does seem to be nicotine. But my question is, in those experiments, I think they gave nicotine through oral drinking water. So I'm not so sure that your conclusion that you need a bolus rapid inhalation is necessarily the case. In other words, if drinking water worked, why wouldn't a patch or other chronic?
Because you don't drink all day long.
Well, a patch
No,
would
but
be.
you don't drink water all day long, it is pulsing.
Well, but the absorption through the gut is over 90 minutes and slow. So presumably you would get a lot of that desensitization. But even with the patch, which is very steady, I think you do get activated. You get, as John Lindstrom would say, you get smoldering activation of receptors. That is, you always have a steady state between the desensitized and activated forms. So it's not like they're all desensitized. You will still get steady activation even with a patch or oral or some or buccal, which would be kind of a semi-bolus, but people could have a lozenge. Pouches are now getting very popular, which are essentially nicotine without tobacco leaf. They're like nicotine replacement, but in the form of a more appealing pouch product. So the question though is, what leads you to believe that, other than just the theoretical notion of desensitization, is there any direct evidence that you wouldn't get neuroprotection from a slower nicotine administration route?
So as far as the animal studies have been, they have been by injection and very few by drinking. And so the injection is also pulsatile in a way. In terms of I have few reasons. First of all, they tried nicotine patch in 8-10 clinical trials in Parkinson. And with the exception of one that showed very mild effect, very mild, none of them worked.
But so but that's not neuroprotection. That was to try to alleviate symptoms once there was already disease,
Right.
which is very different.
Right, so you are absolutely right. So in terms of the neuroprotection, because of the in vitro and in vivo studies, there was one study that did exactly what you were mentioning with the drinking nicotine. And they gave it to Parkinson patients and they reanalyzed the stuff. And there is this freezing posture with and they said that affected that freezing posture. So absolutely. First of all, we want to prevent the symptoms and then prevent the progression. And I truly believe because of all the preclinical studies showing that it has the neuroprotection, not only it would have the alleviation of the symptoms, it would probably not be able to reverse the neurodegeneration, but should be able to slow or hopefully stop it. That's what I believe could do. And the pulsatile versus the patch, again, the steady state that you get, you never do get that with the smokers. You probably know better because of the pulsatile. And then the smoker says the first cigarette in the morning is the most rewarding because they have had the withdrawal. So even the cigarette itself, you take different puffs. So it's the pulsatile stimulation. And I believe that because of that one study, and I have some anecdotal evidence also that when we published this paper on pulsatile nicotine, one of the mentors of my postdoc had developed Parkinson. I said, send me the paper, and he had his physician prescribed nasal spray, and he swears by it. Of course, it's N of one, but that's why I'm dying to get a clinical trial going on.
Well, right, but the fact that the nasal spray worked doesn't mean a patch would not have worked in this case either.
But patch has not worked. That's why I said all the clinical trials did not show any improvement,
Right, once you.
even in symptoms.
I think that the study had mentioned that Paul Newhouse is doing a collaboration where they're giving a patch to look at progression of mild cognitive impairment.
Correct.
If that turns out to show that it prevents the chronic, the progressive degeneration, I think that would also be a test of whether you really do need pulsatile or not. I think it's still an open question.
It's easy enough to do in an animal model, so you could have an excitotoxic lesion, say MPTP or something, and see with osmotic mini pump versus repeated injections,
Yes.
which would be more effective at attenuating that oxidative damage.
Yes,
So,
I think that might be a good
it's a
thing.
study that makes to be done.
But I agree with you, Jed. I think it's possible, and Paul said that he had enough preliminary data to get this big grant, that they had some improvement. But I truly believe that with pulsatile, you would get a much more pronounced effect. That's my feeling. That's what I'm saying.
We can try that. So thanks a lot. It's 3 p.m., 3:02 now. Thanks for a great talk.
My pleasure.
So now you're on the record and people will be able to see it time and again. So thanks a lot.
Thank you for joining.
Yeah, thanks. Thanks for coming by. Yeah.
Thanks, yeah.